Okay, well, good morning, everyone. This is Larry Boris. I'm Executive Director of the National Association for Workplace Healthcare. I want to thank you for joining us for today's webinar on rounding out primary care with employee wellness. This is one of several programs we have. Barbara, would you move to the next slide, please?
Yes.
So, for those who are not aware or of our new name, the National Association for Workplace Healthcare was formerly National Association of Worksite Health Centers. As we have expanded our scope to include direct contracting for services, whether it's primary care, surgical care, imaging, etc., we've changed our name and broadened the services. However, we still remain the voice of those in this industry, both purchasers, providers, vendors, and suppliers. We offer educational programs twice each month. We have networking programs, we have benchmarking surveys, and a huge clearinghouse of information on this field. We invite everyone, whether you're a member or not, to please take advantage of that. Go to our website and our LinkedIn group. Next slide, Barbara, please. So we have some upcoming programs. So I hope you plan for them. Of course, this is today's webinar. We also then have actually we didn't put it on here, but on the first Monday in December, we will be providing the results of our national survey on worksite health centers. So please plan on attending that. Go to our website just to register and get the information. Again, that's the first Monday in December. Again, about 11 o'clock Central Time. Then we have a joint program with Work Conference Forum in Las Vegas. That's an in-person program. We have then a webinar in February on ongoing engagement, and then our own annual forum, April 8th and 9th in St. Louis on employer strategies on worksite clinics and direct contracting. So please plan to join us. More information about these will be sent to you. Next slide. So we're very fortunate today to have Barbara Zabawa with the Wellness Law Company. Barbara has been with us before and provides a great resource for legal and strategic approaches to healthcare and wellness programs. And with that, Barbara, I'll turn it over to you.
Thank you so much, Larry. Hi, everyone. I'm so happy to be here and to talk to you about direct primary care and employee wellness. So in addition to my work through Wellness Law, I am also a law professor at the University of Missouri, Kansas City, where I teach courses in health law, contracts, and wellness law. And I'm just really thrilled to be able to share with you the thoughts I have about direct primary care and corporatization in healthcare and how to integrate employee wellness, why to integrate employee wellness. And a lot of what I'm going to talk about today really stems from a law review article that I just published in the American Journal of Law and Medicine called Corporatization of Healthcare as a Catalyst for Wellness Legal Partnerships. So that's where a lot of the information that I'll be drawing from comes from today. And why I wanted to offer this topic to Larry as a uh, topic to talk to you, the National Association of Worksite Health Centers members, about is because I'm sure you're all aware of the high costs of healthcare, physician burnout in healthcare. Uh, the One Big Beautiful Bill having as part of its agenda the spread of direct primary care offerings, and we're going to talk about how you could leverage that legislation. And then, of course, the employer role in providing health care or health coverage to employees and how this all kind of intersects with this whole concept of direct primary care. So I'm going to start with this problem, depending on, of course, your perspective. It may be a problem and maybe it's not as big of a problem, but according to US consumers, at least in their view of the healthcare system as a whole, um, there is some dissatisfaction in the high cost of care and the low value that they perceive as a system, not maybe necessarily directly with their own providers, but as a system with the care that's being offered in the U.S. health system. And I, in my article that I mentioned, I attribute a lot of this frustration, this dissatisfaction, particularly by employers, physicians, and patients, to corporatization of healthcare. And so corporatization in general shifts care to profit and productivity. So initially, when we as a society thought of healthcare, um, we thought of it as a social contract. The economist Ken Arrow in 1963 talked about how healthcare was or is a social contract where there's this belief, underlying belief that everyone deserves or should have access to health care, and that there's this fiduciary duty that exists between physicians and patients, that kind of supports this concept of a social contract and with access and affordability of care. And corporatization, which I will go into a little bit more detail, can undermine that concept. And as a result of a shift from care to profit, physicians are losing autonomy and patients are becoming encounters and not really part of the care process in a way that they, learning from surveys, they would like to be. And then for the employer side of things, the purchasers of a lot of healthcare, they are having to pay for things that they don't even really know how much it's going to cost. And it's not providing the value that they or their employees are hoping for. And another really interesting statistic that I found is that in 2023, Harris Gallup did a poll of respondents. I don't remember how many people had actually been polled, but 19% of the respondents complained about the medical system's lack of focus on preventive care and wellness. And you all may have heard about this term sick care versus healthcare. A lot of people, at least in academic circles, talk about, the healthcare system being more of a sick care system as opposed to a healthcare system. And it's really focused in on responding to acute events. And that's tied to reimbursement, that's tied to what people are getting paid to do. And so for the patient, for the consumer, the frustration is that there's not enough emphasis for a lot of consumers. They feel like there's not enough emphasis on prevention and wellness. There's not enough, it's very hard to get appointments. That's very costly. In fact, costs is like the number one concern for across all kinds of different surveys of healthcare consumers. There's a huge concern of the escalating costs of healthcare, and plenty of examples of people foregoing or delaying care because of cost considerations. And so with those frustrations by patients, that isn't helped at all by the frustrations that are being felt by a lot of employers who are still, although their role is decreasing, but it's still almost 60% of people get their health coverage through employer-based plans. And every year the costs of those of that coverage is going up, and it right now over across all people, not just employees, it's healthcare spending exceeds $13,000 per person across everyone in the US. But family premiums, and according to some 2023 data by the Kaiser Family Foundation, for employer-based coverage is averaging $23,968 for the total cost split between the employee and the employer. And premiums have grown nearly 3 times faster than wages since the year 2000. So I'm sure this data is probably not lost on anyone, but I just, in case there was anyone who needs kind of that grounding, it's very expensive. Patients are frustrated, um, and physicians are also, on the whole, frustrated. Because of well, there's all kinds of reasons, administrative burdens, compliance issues, um, and just a lack of desire or need to get involved with the business side of healthcare, and that's a huge side of healthcare. It's not why people usually go to medical school. They don't go to learn the business side of healthcare. A lot of them are becoming employed by organizations. Over 127,000 physicians have left private practice since 2019. Um, some of them have just stopped practicing altogether because of burnout. Some of them have been eaten up, or I guess merged or purchased, I should say, by different entities. United Healthcare's Optum division employs 90,000 physicians. In fact, it's the largest employer of physicians in the United States. Um, and a lot of this market power, this consolidation, this purchasing of what used to be in more independent, privately owned physician practices owned by the physicians is consolidating, and that is driving up prices and limiting choice for both employers and patients. Another factor in the corporatization effort, though, in healthcare is not just these large healthcare institutions like United Healthcare and large health systems, but also private equity investors. And this is a large part of my law review article that I mentioned, is the private equity trend in investing in physician practices. It has increased from 2 billion in 2001 to 151 billion 20 years later in 2021. And the playbook by private equity is to try to increase profits as much as possible within a 5 to 7 year time frame, and then sell off the assets, um, and to another buyer, and then the shareholders or the equity investors, can reap the rewards of their investment. But there have been a number of studies on private equity investment in healthcare, and it's not just physician practices. It was nursing homes were one of the first types of healthcare organizations that were being purchased by private equity. And now the trend has been more in physician practices, particularly practices like dermatology, but also primary care practices. I've actually had a number of clients who have been more of the frontline private equity types of physicians that have been entertained by private equity investors. And all the studies that have looked at private equity investment in healthcare organizations, none of them have said, oh, this leads to higher quality and lower costs. Some studies have shown that it doesn't really have much of an impact on cost or quality. But some studies, particularly the nursing home studies, have shown that the quality actually does decrease. And this is because a lot of the tools that private equity uses once it acquires these healthcare organizations is they reduce staff. They try to increase the productivity, both in number of patients that need to be seen, plus the types of procedures and more lucrative types of services that can be billed for to increase revenue. And as a result, prices have risen up to 78% post-acquisition, according to some of the studies that have looked at that. Another factor, though, in the high cost, and which is the main concern of patients and employers in our current healthcare system, is managerial bloat. This relates to private equity because usually the private equity investors are not necessarily physicians or licensed healthcare providers. They are unlicensed individuals who are looking at, a way to increase revenue. And so they often are in a managerial role when they take over physician practices. There are some laws in some states that prevent that, and I'm not going to be able to go into corporate practice of medicine laws that can interfere with some private equity investments. But regardless, even without the private equity, healthcare organizations rely a lot, increasingly so, on healthcare managers. Um, so that's part of the administrative costs. Healthcare managers have grown 3 times faster than physicians since 1970. And administrative overhead is more than 30% of total spending on healthcare. And when you divert funds from care to billing and management, that is part of the reason why we see increased costs. So that we have these managerial roles, these managerial departments in healthcare organizations that kind of are acting as a barrier between the providers of care and the patients who are receiving that care. This chart is just another chart showing the increase in the number of employed physicians who are now becoming part of the corporate enterprise of healthcare as opposed to being independently owned and practicing within a group practice, independently owned group practice. So you can see that its corporate employment has climbed amazingly high since 2000. And then here's another chart that's looking at private equity investment in healthcare. And you can see how it's just grown exponentially since the year 2000. So, as I say in my article, given this landscape of corporatization in healthcare, the losers, the biggest losers in this trend are employer purchasers of healthcare, physicians who are providing the healthcare, and the patients who are the recipients of healthcare. And that's because the care that, on the whole, again, not looking at individual situations, individual stories, but on the whole, patients are paying more. The types of care that they're receiving aren't necessarily the types of care that they most want, would be more preventive care, but that's not really a reimbursable service in most instances. The long discussions about lifestyle and health choices and how you can prevent disease and illness is not something that physicians are given a lot of time to do. Not saying that they don't want to do it, but they're not given the priorities that are set by corporate interests in healthcare to be productive, to bill for higher revenue generating services. They don't have a lot of time or energy to spend with patients that to discuss healthy lifestyles and how to prevent disease and illness in a way that would be more meaningful for most patients. And then employers are paying for health services that the studies that I cite to in my article, the employers don't even know most of the time how much plan is really going to cost. Um, and so they're kind of left at the mercy of bigger players than them, bigger health systems that are continuing to consolidate, bigger insurers that are continuing to consolidate, and they are having to offer services, healthcare coverage that may not meet the needs or the wants of their patients, and it's certainly not in what many physicians would like to be able to deliver in terms of care. So, just reiterating, the traditional medical delivery system that we have reacts to illness rather than prevents it. That's where the financial incentives lie mostly, is in reacting to an illness and and not really putting a lot of effort or resources into trying to prevent it. Um, and so, how can we fix this problem of not emphasizing prevention to the point where that it meets the consumer needs and wants? Well, one area that is trying to address prevention, lifestyle choices, is wellness. And there is a lot of companies, there are a lot of companies that invest in corporate wellness to maybe try to balance out more acute care that is provided on the medical side. So this slide is just listing for you typical costs per employee that a company might spend for a corporate wellness program, with the lowest cost plan being, anywhere from $36 to $90 per year per employee for a digital wellness platform, to more comprehensive type programs that have more activities and more in-depth kinds of coverage for preventive services that might, cost $800 a year or more for per employee. But the point that I want to make with this slide is that a lot of employers do invest in wellness already, in addition to investing in healthcare coverage for their employees. And some of the typical wellness activities that they're investing in are health screening activities like risk assessments, flu shots, virtual health coaching or on-site health coaching to go over results and have discussions, those longer discussions with employees about, things that they can do to improve their lifestyle to ultimately prevent disease and illness. Other activities might be fitness, physical well-being activities. There might be some nutrition and healthy eating activities, education programs. Again, that can be woven in with the coaching programs. Mental health and stress management. That I'm going to be talking about that next month, about mental health and wellness. And and I actually just came from Honolulu last week where I talked about psychedelic treatment for mental illness in the workplace, and the legal side of that, and using ketamine assisted therapy as a way to address PTSD, anxiety, major depression. Those might be some of the areas that an employer might look to corporate wellness programs to address. Maybe not the ketamine part, but other ways to deal with employee mental wellness, financial and work-life well-being, and then social and community health. And I can't emphasize that last one enough, social and community health. One of my biggest criticisms of employee wellness is that it does a great job with employee lifestyle behavior change. But I would love to see employee wellness take a step back and look at the bigger picture of social determinants of wellness and what can employers do to break down barriers that get in the way of employees engaging in healthier behaviors. Where do they live? Do they have access to healthy food? I mean, you can tell people eat healthy food all day long, but if they don't have access to it because they live in a food swamp or a food desert, that's something that maybe employers could help address through different community efforts. And same with, if domestic violence and housing and all that other stuff that factors into and influences your well-being, and it doesn't really have anything to do with your lifestyle choices. It gets in the way of your being able to make those choices. And so social and community health is really, really important. And those can all be part of a corporate wellness program. So, where is this going? This is going solely to the direct primary care model. Um, and the One Big Beautiful Bill Act, the OBBB, I think the A might be redundant, uh, gave an opportunity to really take a harder look at direct primary care as a potential solution to some of the frustration that I explained that is occurring because of corporatization in healthcare. So, the One Big Beautiful Bill has a provision that deals with health savings accounts, and I'll talk about that in a moment, um, and how you can use health savings account dollars for direct primary care. So what is direct primary care? And this has been in existence before the One Big Beautiful Bill. Many of you probably already know about it, but just to briefly explain what it is, generally speaking, it's a flat fee membership primary care model. So it can be done through a primary care clinic directly with consumers, directly with patients. Patients pay a monthly membership fee for access to direct primary care practice. It could also be called a concierge care practice, but for that fee, they get certain services every month for them, or they can have a family-based fee. And there would be no insurance. It's just cash-based. And as a result, there's no middle intervening entity for the direct primary care. At least ideally, conceptually, that's what is thought of. And because it's a membership model, the physician or primary care provider has the flexibility to decide how many members they want, how much their membership fee will be, and how much time then they can spend with each patient to really get to know them, to really give them the kind of preventive guidance that, according to the polls, consumers say is lacking in traditional healthcare models for the most part. So, what does the One Big Beautiful Bill do exactly with regard to direct primary care models? Well, it was signed into law on July 4th this year, and it specifically expands health savings account flexibility. So, in case anyone isn't aware of health savings account, they are a tax favored account you can contribute to as an employee or as an individual in the marketplace. If you have a high deductible health plan. So you have to have a high deductible health plan that meets certain criteria in order for you to qualify to contribute pre-tax monies into a health savings account and then use those funds to pay for medical care expenses. And that requirement that you have to have a high deductible health plan in order to be eligible to contribute to a health savings account has been the tricky part of health savings account eligibility. Because if you have a high deductible health plan, and let's say you get another kind of benefit that might supplement the high deductible health plan, there was this fear that that other additional benefit would basically disqualify you now as not having a high deductible health plan because you actually have a richer benefit plan with that additional benefit paired with the high deductible health plan. And so now you're no longer able to take advantage of the tax favored health savings account monies. And so there's been this fear with employers of like, well, we offer a high deductible health plan, so we don't want to offer any additional benefits that might jeopardize that status of the high deductible health plan and therefore basically eliminate the tax favored benefits of the health savings account. So what the One Big Beautiful Bill did was it clarified that direct primary care models that meet certain criteria. So it's not just any DPC model, and we'll go over what criteria need to be met. If you meet those criteria in your direct primary care model, you will not jeopardize your HSA account. You will not jeopardize the high deductible health plan status that you might otherwise offer to your employees. So, the One Big Beautiful Bill allows high deductible health plans to cover primary care with HSA dollars and and not have to worry about the tax savings going away. So, what qualifies as excuse me, a primary care provider under the One Big Beautiful Bill? So, in order for you to take advantage of the HSA high deductible health plan flexibility that the One Big Beautiful Bill offers, is the direct primary care program has to be provided by a primary care physician or a nurse practitioner or clinical nurse specialist or a physician assistant. What is a primary care physician? According to the language in the law signed on July 4th, it's a specialty, a physician whose primary specialty is family medicine, internal medicine, geriatric medicine, or pediatric medicine. Now, there's some lingering questions. I know that some of you might wonder, physician, like what kind of physician? An MD or DO only? Or what about podiatrists or optometrists or other doctors that might be listed in the law as qualifying as physicians? I am expecting, everyone is expecting there to be additional guidance at some point that will clarify more about what is meant by some of these physicians whose primary specialty could be any one of these types of areas. This provision with the HSA dollars being able to be used for direct primary care takes effect after December 31st of this year. So starting in 2026, this can happen, but it may be happening in a world where we don't have all the answers from a legal standpoint of what truly qualifies. So just be aware that eventually guidance will come out. But if you're interested in taking advantage of this, you can start doing it next year. Just know that you might have to be a little flexible as we learn more about what Congress meant by some of the language that they chose. Some of the things you cannot do as through a direct primary care model in order to qualify again for that HSA use is you cannot offer through the direct primary care clinic general anesthesia procedures, prescription drugs other than vaccines, or lab services that are not typically administered in an ambulatory primary care setting. And I know you might be asking, well, what is meant by that? I don't know. That's another area that we need additional guidance on. Like, what do you mean by lab services not typically administered? So those are still some unanswered questions that we have. But again, if you're interested, you can go forward starting in 2026, just knowing that you might have to adjust as more guidance comes out. Some other requirements that you need to meet in order to take advantage of that HSA eligibility to be able to use HSA dollars to pay for direct primary care is that the fees, the monthly membership fees that define what a direct primary care model is, can't exceed $150 per person per month. Or if it's a family, can't exceed $300 per family per month. But as long as you can meet those requirements, you have the requisite people delivering the services. You don't deliver things that are not considered primary care, like labs that aren't typically delivered in primary care settings, or general anesthesia, or prescription drugs other than vaccines, and you don't charge more than $150 per person. You could conceivably allow employees, as an employer, you could offer high deductible health plan and a direct primary care model and allow employees to use HSA dollars to pay for the direct primary care, or you could pay for the direct primary care and they could still have their HSA dollars for other medical expenses to meet to use pre-deductible, meeting the deductible. So how can you leverage this legislation that's basically promoting direct primary care through the use of HSA dollars with corporate wellness? Um, and so that's ultimately the message that I want to convey to you, is that traditional healthcare coverage is not meeting the needs of employers, physicians, and patients. Corporate wellness, companies are spending money on corporate wellness programs that meet some of the preventive needs of employees. But direct primary care is another way, an alternative to allowing physicians to practice instead of in a corporate setting. They can practice in a direct care setting. There's direct specialty care too, but the legislation just deals with direct primary care, and can be a little bit more transparent as far as pricing for employers, and because it's a direct contract between the employer and the provider. So it and the direct primary care in particular can integrate a lot of the corporate wellness programming that is already occurring, because ideally, a primary care physician or a nurse practitioner um, has the training and a lot of times, usually the drive and desire to offer a lot of preventive kinds of services, but in the corporate setting is unable to because of demands by the corporate interests. So direct primary care is giving them an outlet to integrate more of the corporate wellness. And so combining the two concepts into a direct primary care model might be very satisfactory for all kinds of stakeholders. And so that's really the message that I wanted to convey, is kind of putting together all of these separate frustrations and interests into one model that can be designed in a different number of different ways. You could use an on-site clinic to deliver the wellness services directly um, by either the direct primary care providers, or the direct primary care providers could contract with wellness providers, coaches, and others who could deliver the wellness services through the clinic or the umbrella of the direct primary care model. The employer could pay for the entire thing as a benefit, or could split the costs with the employees, who now can use HSA dollars for primary care services through the DPC model. Some cautions that I would give you if you're thinking about doing something novel like this is to carefully draft your contracts and employee facing materials to clarify that the direct primary care is not insurance and does not cover hospitalizations, specialty care, or catastrophic services. That is the role of the high deductible health plan, which would likely be paired with the direct primary care model in the employment setting anyway. And this is important because one of the hesitations over the years, like I said, the direct primary care is not a new concept. It's been around for a while. What's new is this one big beautiful bill, HSA dollar connection. But one of the hesitations that I've encountered with individuals, providers who have been interested in direct primary care, is that will it be considered insurance by the insurance commissioners of the state in which they're located? And it's not a slam dunk yes or no. Some states have passed laws carving out explicitly direct primary care is not being considered insurance. I think about half the states might have a law that explicitly carves out direct primary care from insurance regulation, which means another half of the states haven't said anything about it. And so there's a question of whether an insurance regulator might look at a direct primary care model, particularly one that offers unlimited services for a flat fee every month to a pool of people. A question, is that an insurance plan that needs to meet insurance regulations of the state? Because no, no physician's going to want to get involved with that kind of regulation. And so, in your contracting, make sure that you are um, crafting the model to be as uh, unlike insurance as possible and to be explicit in your documents that this is not meant to be an insurance plan, to try to mitigate any risk of being labeled as an unregulated insurance plan. And then also, if you're going to include health coaches in your direct primary care model, which would be a really good idea, because I mean, even if a physician themselves wants to deliver preventive services and have long discussions, financially they might decide it might be more efficient if they delegate that service to a coach, who could work with the direct primary care clinic. Just make sure that that coach is really operating under the supervision, general supervision of the physician, so that it's um, considered a medical expense. Because remember, HSA dollars must be used to pay for medical expenses. And when you start getting involved with some wellness services, there might be a question of, oh, is this medical expense under IRS, Internal Revenue Code Section 213D, that can be used for tax favored accounts like HSAs, or is this really like a wellness benefit, like a gym membership, which you can't use HSA dollars for? So integrating the wellness benefit into the direct primary care services and having the physician oversight may allow for more wellness services to qualify as medical expenses, which would be then reimbursable by HSAs. So just something to keep in mind as you're thinking about possibly taking advantage of this new legislation. I do not have any connection, or I don't even know this Wellspring direct primary care group, but I just wanted to like find maybe a model of someone who might be already doing what we're talking about, what I'm talking about. So this Wellspring direct primary care and lifestyle medicine group, I'm not even sure where they're located, combines family medicine and lifestyle medicine. They offer wellness coaching for nutrition, activity, and sleep. They have a membership model that enables behavior change and prevention for a flat fee. So there's already direct primary care models that are integrating wellness into their service offerings. And it might be something that employers would be interested in looking at as a way to provide more holistic kinds of services instead of fragmented wellness here and then medical plan here. Um, and I just want to make sure there's enough time for questions. These last few slides are just giving some examples of how you might integrate wellness and direct primary care. This one is integrating it in the on-site. If you have an on-site clinic, how you might use the on-site clinic for direct primary care service offering and wellness offering. This hypothetical is looking at how you might integrate a direct primary care with a virtual primary care model. So using telehealth, um, and that could also include wellness services. So it doesn't have to be an on-site model. It could be a telehealth model. There's also some telehealth um, provisions in the One Big Beautiful Bill to allow telehealth to telehealth would not undermine HSA eligibility either. That was made permanent, so that's a good thing as well to take advantage of. And then the direct primary care, this is just saying that the direct primary care providers would offer wellness services themselves um, as a as an additional service offering, sort of like the Wellspring example that I gave earlier. Um, so integration of wellness and direct primary care makes sense to me. It makes sense, I think it would make sense to a lot of consumers who are kind of craving that more uh, personalized attention from their primary care doctor, more emphasis on preventive care and less on sick care. And employers would have happier employees, presumably, if they offered that kind of model. So I think this is just redundant, and I'll just skip that. So if you are thinking about maybe moving forward with this concept, make sure your direct primary care vendor is aligned with wellness goals. Are they willing or already incorporating a lot of lifestyle type medicine services into their practice? Um, are they willing to maybe measure engagement, participation, health outcomes, cost savings as part of the service offerings to you to see if they're moving the needle on different metrics that are meaningful to your employee population and of course, your bottom line. Um, and what methods do they use? Is it an on-site clinic, a mobile unit, hybrid, virtual options where they would deliver those primary care and wellness services? And if you're on the provider side of this model, um, think about expanding your service offerings to include and integrate wellness concepts into your primary care delivery, knowing that that's what
Barbara, you've gotten frozen on your signal here.
your HSA
There we
high
go.
deductible health plan, the eligibility, partner with compliant direct primary care vendors, um, embed those wellness initiatives into your contracts. Make sure you kind of, with those caveats that I mentioned earlier about not being insurance and making sure that whatever wellness activities are embedded, that they can be used as as a reimbursable medical expense. And then track data to see if it's working, if it's lowering your spend, improving outcomes and satisfaction, because that will be interesting and important going forward. And yeah, I think I've kind of already covered these. And this last slide, I just want to have the takeaways. Corporatization is fragmenting care. It's not delivering the types of care that, at least according to a lot of the studies and polls, that patients, physicians, and employers want. And direct primary care is no guarantee, it's not a panacea, but it's possible that it could restore some of the connection and make care more holistic and meaningful to those stakeholders. And the One Big Beautiful Bill creates a pathway to explore with this concept using HSA dollars. Um, and integrating wellness programs that are already out there as part of the direct primary care could consolidate and make things more efficient and budget friendly. Um, and employers and providers, this direct primary care model gives them a chance to partner more directly without the middle um, players that sometimes can make things less transparent and more expensive. So with that, I will turn it over to Larry or anyone else who may have questions for me.
Great. Thank you very much, Barbara. We very much appreciate your time and the expertise and perspective on this. Now, what I like to do is we typically go around the table. I will be calling out your name based on your showing up on my computer screen for any comments or questions or observations you might have. So let's start out with Eric Robertson. Eric, any comments or questions? Eric, unmute yourself. There you go.
Yep. I don't have any questions right now, but I do think it was very informative session. I greatly appreciate the analysis that was provided and how the the programs can interact with primary care services. So thank you.
Thank you. Juliana Perry. Juliana, comments, questions?
Afternoon. Yes, thanks for the presentation. I am wondering if you have some insights into some effective ways to track outcomes from prevention.
Outcomes for prevention. I mean, over time, it's a long-term kind of analysis. As far as consumer satisfaction, those metrics could be measured pretty easily. But as far as like preventing disease, I mean, that's a public health issue. That's a longitudinal kind of analysis that, the provider would have to engage in, and hopefully there would be some long-term employees that you could, follow over time.
Yeah, I think when you're talking about preventive care, you have to look at whether they're getting increased risks or reducing risks. And usually the biometrics is a great way to do that. But it does time consuming, and you have to do it every couple of years or so to see how people are. But determining the number of people getting flu shots, A1C scores, you can do within a single 12-month period.
Thanks.
Okay, sure. Hannah Bach. Hannah, comments or questions?
No comments or questions. I really appreciate this as I am working from a direct primary care company with a wellness platform. I also am curious about the reporting kind of structure that you have, but I understand that's a whole different can of worms when we're opening that. But great presentation. Looking forward to take some more takeaways from this and reflect on it. But thank you so much.
Great, thank you. I've got someone listed as Indiana University Benefits. I don't have a name here, but if you would comment, please. Any questions? No? Okay. Julie Gallon. Julie, any comments or questions?
No, I thought it was a great presentation. Whoop. Can you hear me?
Go ahead. Yeah, go ahead.
I just said it was a great presentation. Thank you for the information.
All right.
No questions.
All right. Karen Maria. Karen, any comments or questions?
No, I don't think I have any questions. I'm looking forward to sharing the presentation with some of my other employees. I also work for Primus Health with Hannah. So I'm excited to see the deck and the recording come out so I can share this with my team.
Great, thank you. Catherine Morrison. Catherine, any comments or questions? No? Okay. Keith. Keith, any comments or questions from you?
No, I'm good. Just thank you for the presentation. Loved it.
Thank you. Byung Kim, any comments or questions? Byung?
Thank you.
All right, okay. Reese Jameson, any comments or questions, Reese? Okay. Sue Gooding. Sue, any comments or questions? All quiet. All right. Tracy O'Neill, any comments or questions you have?
I would go back to I also am looking forward to sharing this with my team. I think there's a lot of good nuggets of information that can help support our program, and just some of the thought processes and how we're developing our program and knowing how to essentially sell this to our employers who may not have an understanding, but at least get the the nugget in their ear that they could go back to their teams and figure out legally how to incorporate us as a direct to primary care solution for them. So I do appreciate that.
Great.
The other thing about the measuring, it is a challenge. We are currently trying to develop an at-risk, bilateral at-risk program. We have not yet put it out there, but that is one thing that we are trying to figure out is how to measure this in order to help employers understand not just the soft numbers of, oh, employees like it, or they really enjoy that so-and-so spends a lot of time with them. But, you know, I think for employers, it's where the rubber hits the road. And if we look at risks, increasing risks, decreasing risks, we can really only extrapolate based on population health and public health data as to this. You know, we have a population of 100 where everybody's blood pressure is below this much. Theoretically, we've avoided this many heart attacks or something like that.
Right.
I mean, those aren't real numbers, but that's something that we can utilize as a measure. Obviously, it would be helpful. A lot of times would be actually just over time looking at even healthcare claims, like maybe we have less hospitalizations for heart attacks over the next 5 years after we get this great program. And maybe there's less out-of-pocket expense for the employers for these different programs and stuff. But I don't think there's been a lot of work in utilizing that data. And I think it's very hard to get. That's the other thing is we even use Epic in my program. And I think Epic has a lot of utilization, but I don't think they're really set up for this type of manipulation of information to kind of look at how does this affect costs and things like that.
Great.
Great
Well,
point.
so, Tracy, well, if you haven't received it already, the NAWIC Guidebook for Measuring the Performance of Worksite Health Centers has a variety of metrics that you can use both in a variety of ways, both again in primary care or in satisfaction and utilization, productivity. Really covers the whole what I call value of investment approach to measuring performance. So if you don't have that as a member of NAWIC, we'd be glad to send you another copy of that. It's also on our website. Well, with that, we're coming to the end of the hour. Again, I want to thank Barbara for her good time and her expertise. I want to thank you all for participating and hope you'll come back for the first Monday roundtable where we go over the results of our National Worksite Health Center survey. So thanks, everyone. Have a good Thanksgiving. Hope to talk to you soon. Bye-bye.